Hi, this is Dr. Alan Brown. Welcome to Lipid Insights. We are broadcasting live from the National Lipid Association meeting in Miami, and I'm thrilled to be able to talk to Dr. Dinesh K and Dr. Kevin Maki about a presentation they just did on a meta-analysis of effects of LDL cholesterol lowering on major adverse cardiovascular event rates. Now, that might sound like something you've all heard before, but this is actually in primary prevention trials. And there's been a lot of debate over the years about whether LDL lowering has a significant impact in primary prevention patients. So I'm really excited to hear a little bit more about the data and what they found. So thank you guys both for joining me.
Thanks for having us.
Thanks for having us.
So let me start with you, Kevin. Tell us a little bit about the methodology and what trials did you choose of primary prevention to try and gather this data?
Sure thing. Well, I'll go back and give you some of the background that led us to undertake this. And so in 2012, the cholesterol treatment trialists did an analysis, and they looked specifically at lower risk patients. And what they found surprised me at the time, which was a little bit more relative risk reduction per millimole per liter, lowering of LDL cholesterol in the lowest risk patients as compared to higher risk patients. And so that wasn't what I expected. So, that was one of those things where I said, that's funny. And then later they did an analysis to look at primary versus secondary prevention. And there was a little bit of a trend, but it wasn't statistically significant. But that also trended toward a greater reduction in risk per millimole per liter lowering of LDL cholesterol in primary as compared to secondary prevention. Then later on, we had 3 trials published in primary prevention: Utopia 75, Reprieve in HIV patients, and then the Clear Outcomes subgroup for primary prevention. And all of them had risk reduction of 30% or more. So that said to me, hey, we need to really look at this and quantify so that we can get a better estimate of the benefit of LDL cholesterol lowering with drugs that primarily target LDL cholesterol reduction in primary prevention.
Yeah, I was struck by Clear Outcomes had the same result. They also had a better relative risk reduction in the primary prevention subgroup than secondary. And I kind of thought it's probably just error variability, because I had a rule over the years. I called it Brown's Law number 5, that anything that works best in the highest risk individuals. So this is very intriguing to try and figure out, whether that data was real and why. And then Dinesh, you obviously are not only an excellent imager and now an excellent preventative cardiologist. How did you get involved in this, and what was your interest?
Yeah, so Kevin and I had talked about this when we reviewed the data on the 3 trials he mentioned, and it really sparked our interest because if you go back, as Kevin said, 2012, all of the guidelines at that point were talking about no significant benefit for statins in low-risk primary prevention. So there was a lot of debate about where to set the threshold to initiate statin therapy and if that meant anything relative to risks. And once we saw data from Reprieve with a hazard ratio of 0.65, 30% or more reduction in the primary prevention arm, we said we really should look at this systematically. And at that same time, the coronary imaging data was coming out, which showed that maybe the best time to intervene for plaque reduction is when plaque is still young or nascent, as opposed to when you have a lot of calcified plaque or somebody who's already had an event, as in secondary prevention, because by that time the horse has already left the barn. So your biggest opportunity to make a difference is early on in the disease process, and that's what led us to do this analysis.
Yeah, that's actually really fascinating. I mean, when you look at the genetic data and you see that if somebody had a knockout of NPC 101, so they had genetic ezetimibe their whole life and getting an 80% reduction in their lifetime risk, as opposed to what you could do in 5 or 6 years after they have disease. But nobody's actually looked at that carefully in the past, which is why the rumor is always out there that you don't get much benefit for primary prevention. So I'm excited about this. I haven't seen all the data yet, so let's hear a little bit about what you guys found.
Sure. Well, we found a group of 15 studies, and those 15 studies included pure primary prevention, and then 3 studies that were mostly primary prevention, at least 80% primary prevention. And we looked at the analysis with those not pure primary prevention excluded and included. The results were not different. The primary outcome was 4-point MACE, and so that's cardiovascular death, non-fatal MI, non-fatal stroke, or coronary revascularization. And what we found is that per millimole per liter lowering of LDL cholesterol, there was a 30% reduction in risk, and the 95% confidence interval went from 25 to 34%. And so what that means is it was a larger risk reduction than the 21% based on the overall CTT analysis that included both primary and secondary prevention. So this supports the idea that lower for longer is better when it comes to LDL cholesterol, as the folks from the MNLA have been saying for a long time, but also that, as Dinesh said, early on is when you probably have the most potential for benefit. And so I say that lowering LDL cholesterol is like saving for retirement. Earlier is better.
Right. It's a 401k plan, right?
Yeah, exactly. 401k for arteries.
For our audience members who don't correlate millimoles per liter to milligrams per deciliter, what does 1 millimole per liter translate into?
It's about 39 milligrams per deciliter. Technically 38.7 for the purist, but about 39.
So, Dinesh, any other fascinating findings here? And then what do you think the takeaway points should be in terms of who would be appropriate LDL lowering patient? So not only about statins, because some of the trials you analyzed were not statin trials, right? So tell us a little bit about what your takeaways are.
Yeah, so the highlight, as Kevin pointed out, is that we had a hazard ratio of about 0.7 or a 30% reduction in the overall groups. And then even when we did a subgroup analysis separating 2 groups, the median level of risk reduction was about 6.9. And if you separated the groups below and above that, you still saw consistency in those results. So that was the main highlight. The second highlight, I think, from the perspective of the guidelines, it's, always been, now it's clear that you have the pooled cohort risk equations, and if you have a 10-year risk of more than 5 or 7.5, statins have a greater benefit. When these trials were done, they were looking at 5-year risk, and they were looking at a major vascular event rate of less than 5% as not being maybe in the benefit range. But what our analysis shows us is that not only with statins, but also non-statin drugs such as bempedoic acid, you do actually have that preserved benefit even in the very low-risk group patients. What we couldn't tell from our analysis is where's the lower boundary at which the risk is so low that you want benefit from a statin. And I don't know whether that's 1% over 10 years or 2% over 10 years, but I think future studies will have to analyze that and answer that. And the good news is most of the trials that are ongoing these days, including the ones with Lp(a), have a primary prevention arm built into those. So we'll have that data not just for statins and other non-statin drugs, but also for the Lp(a) lowering agents. So we'll be able to characterize both plaque regression by imaging as well as lowering of LDL and other atherogenic lipoproteins, and be able to determine with finer granularity as to where's that lower risk level above which you start to see some benefit.
So if I'm hearing you correctly, to summarize, at levels as low as 5%, you saw this very significant reduction in risk. And then over how many years are we talking about, a 5 or a 10-year risk?
So the trials ranged from about 2 years to a little bit less than 6 years in median follow-up time. And we did not actually find a relationship between the length of the trial follow-up and the degree of risk reduction. But what we did consistently find, sometimes statistically significant, other times just a trend, was that the lower the risk of the group being studied, the greater the relative risk benefit. But we always have to keep in mind that it's not only relative risk that matters, it's also absolute risk. So if you start with a group that has 20% 10-year risk and you lower their risk by 10%, that's going to be a 2% absolute risk reduction. And in a group that has a 5% risk, you lower their risk by 10%. That's only going to be a 0.5% absolute risk reduction. So both are important. They're kind of complicated concepts that a lot of clinicians struggle with. But the key point is that the greatest potential for benefit occurs when you start early and when the person's still at relatively low risk. So when they don't have advanced calcified plaques.
Okay, so
And I'll just add to that,
please.
There's obviously a lot more patients who fall in the primary prevention bucket as opposed to the secondary prevention bucket. So when you look at worldwide population, your ability to make an impact with this sort of analysis is larger in terms of the absolute number of patients who will benefit. Even though the absolute risk reduction is smaller in the primary prevention patients, there's far more of those patients. So the magnitude of patients you can impact is higher with that.
Yeah, and I think when we used to look at absolute risk and identify number needed to treat from that, a lot of it had to do with economics also, because at the time when we first started doing these interventions in lipidology, that drugs were expensive and out-of-pocket costs were expensive, but now many of them are generic and almost no cost to the patient. So that changes the game quite a bit when looking at broadening the population. And of course, being cautious about potential deleterious effects of putting people on meds. So I think if I were an audience member listening to this, there'd be a lot going through my mind, like what was the average LDL levels? But that isn't so relevant when what you're looking at is risk to determine treatment. So could you speak a little bit to that it wasn't so much LDL level, it was a global risk? And how did you determine that? And, how should our audience members think about it?
Yeah, so just to clarify, the subgroup analysis that I think is most important is what was the median percentage of participants in the control group that had an event, and that was 6.9%. And these trials, averaged 4 to 5 years. And so, you're talking about intermediate risk. For the most part, these trials were done in patients that did have some degree of elevation in LDL cholesterol. And so we have to be careful about not trying to overgeneralize. But again, under 6.9%, and 5 of the trials had an event percentage of less than 6.9% in the control arm. And so in those trials, there was a 34% lowering of risk. And so this, again, is consistent with the idea that for people with elevated levels of LDL cholesterol, earlier intervention for a longer period of time is likely to produce larger benefits.
And what were the total number of patients you analyzed in the meta-analysis?
Oh, I don't remember offhand what the total number was, but, these are generally trials with thousands of patients. So we're talking about a large number that's probably around 100,000 people.
All right. So this is very, very interesting. It's encouraging. Did you think about, how many of those patients you might cause insulin resistance in if you went out and said we should we should do this on a lower risk group of patients and look at the number needed to harm versus the benefit? Because, it's one of our colleagues will bring that up.
Well, this is a consideration. So with statins in particular, they do produce some degree of insulin resistance. And we know that in people who are predisposed to develop diabetes, they will have their risk somewhat increased by taking a statin. But there are other agents available now that don't have that effect. So ezetimibe and bempedoic acid don't increase risk of new onset diabetes. There are other drugs in development that do not. PCSK9 inhibitors don't, although that wouldn't be where you would think of going in a primary prevention patient generally. But there are trade-offs, and we don't want to give the impression that we should be giving everybody a statin. But for people with moderate risk, the earlier they start, the better off in terms of cardiovascular risk reduction.
That certainly makes sense. Dinesh, did you struggle a little bit that you were looking at different classes of drugs, probably different doses of drugs, and a different degree of LDL lowering? So how much variability did you see, and how did you guys account for that?
Yeah, that's a great question. So, this was a pooled meta-analysis. It was 15 studies. The majority of the studies had statins, and only a couple of the studies had non-statin drugs. And this is not a patient-level meta-analysis where we had individual patient data on all of this. So those are some of the limitations of any large meta-analysis like that you do. But nonetheless, many of these studies had statin versus control. Some of the studies had high-dose statin versus low-dose statin, and the results were consistent across these groups. I just want to go back and make a point about the diabetes, which you raised as an excellent point, and Kevin answered it really nicely. But I want to remind the audience that even in the pre-diabetic or diabetic population, the benefit of a statin far exceeds the small risk of developing diabetes. And if you think about who develops diabetes, it's the folks with borderline A1Cs of about 5.8 or so. And it generally is thought that the rate of diabetes development is accelerated by about 2 to 4 weeks, which is trivial when you think about the long-term cardiovascular risk for these patients. Now, granted, these are primary prevention patients, but if you look at the relative risk reduction, that's 30%. And overall, it's thought that the risk of increasing diabetes is less than 5 or 10%. So I think that's sort of the way I would think about this. But getting back to your point about the different doses of statins and different kinds of statins, we really weren't able to analyze granular level data as to specifically which statin may have benefited. And these were done across a time span. So, at different points, different statins were in vogue. But these days we have much safer and more potent statins. So I don't think that would change the overall implications of our data.
And I'll add one thing to that. The three most recent trials, Reprieve, Utopia 75, and the Clear Outcomes Primary Prevention, all three of those had 30% or more MACE risk reduction per millimole per liter lowering of LDL cholesterol. And so that's three separate agents where you're seeing the same effect. And in a contemporary group of patients who, are receiving modern preventive care.
Any final thoughts on why you would see a greater reduction in the primary prevention patients than the secondary prevention? Or is it a matter of over time, the length of time they're being looked at? That was very confusing to me in Clear Outcomes.
Yeah, I think, we'll go back to that concept about it's easier to stop a plaque from developing or progressing when it is young and still accumulating lipid, and to prevent rupture or erosion, as opposed to somebody who has developed mature plaque, has a lot of ongoing inflammatory activity, and then tends to rupture one of the hundreds of plaques that are there in the coronary. So the best time is to start early. I'll go back to the 401k analogy, which you guys gave, which I love, by the way, that the earlier you start, the bigger bang for your buck you get over the years. And so that's the prevailing consensus in the imaging community, that young atheroma is far more malleable and you can cause regression as opposed to atheroma that's very burned out or more mature.
Well, you're giving me hope because I started a statin 30 years ago. So let me ask you guys to each give your 1 or 2 sentence snippet of what you'd like the audience to take away from the work that you did. And congratulations. It's really provocative, and I think there'll be a lot of buzz about it. So, Kevin, I'll start with you.
Sure. Well, I'll say it maybe for the third or fourth time. It seems that lower for longer is better when it comes to LDL cholesterol. And starting early for people with elevated levels seems to be the most beneficial.
Yeah, I'll echo that sentiment, but I'll also say there's a lot of negativism on Dr. Google or in the patient community about the perceived side effect of statins. And now we have 50 years of data and hundreds of thousands of people that these are safe, well-tolerated, really effective agents. And this sort of data just puts a feather on the cap of, even the low-risk patients, which we perceive are perhaps not going to benefit as much. This data turns that around and shows, no, actually, you get a larger relative benefit in those people. So I think it's another data point where you can convince your patients, this is why we're giving you a medication. Certainly continue with diet, exercise, therapeutic lifestyle. But if they have an elevated risk, even albeit small, they still benefit from lipid-lowering therapy.
Well, I appreciate both of you, and I appreciate the work you did. I think we have grown up in an era in my 40 years where we're so worried about overtreatment that we looked for reasons not to treat, and we were criticized for overtreatment despite that. And this is a completely different paradigm to think about. Go ahead and treat early that you'll actually get better outcomes than waiting, and something that I think we're going to have to think about going forward, considering that despite all our best efforts, ASCVD is still the number one killer with all the gains we've made over the years. So thank you both for this wonderful analysis, and I hope it tweaks everybody to rethink some of the clinical trial development.
Thanks so much. It's been a pleasure.
Thanks for having us.